Hi, Mohammed Al-Mala here, here to share another full-length cataract surgery case with you. Welcome back to the channel. This is another case of a cataract surgery, patient undergoing cataract surgery. If we look, we're joining, as we've already started the case here, we've already started the capsulorhexis, and we're doing capsulorhexis forceps here. Before we remove the capsulorhexis, you want to note that this patient has pseudoexfoliation. So you see the rings that are just inside the iris margin and another ring that's just close to the center of the pupil there, which I've now just removed. But those rings are indicate pseudoexfoliation, and that's a pseudoexfoliation material deposited on the anterior lens capsule. We don't see any between those two rings because that's the range of which the iris naturally moves. And as the iris moves, it sloughs that material, prevents it from sticking to the capsule. So we're doing our hydrodissection here. We see a nice triangle sign there, one fluid wave. So we should have a good cortical cleaving hydrodissection here. We'll come in now with phaco, and we want to check the irrigation and make sure there's no air bubbles in the sleeve. Enter the wound. We go side to side there just so we can traverse the wound without getting caught up. And then we're going to impale the nucleus and come in with our second instrument and do a horizontal chop. We'll see that there's a little bit of shallowing of the chamber here, and that can sometimes happen before we've had enough BSS in the anterior chamber to create the chamber. So we've got a fairly good crack here, and the lens is rotating, and we're going to go ahead and remove, chop the first heminucleus. Decent crack here as well. And then we got a pretty good rotation. We've got one heminucleus left that we need to chop into quadrants. And so this is a horizontal chop technique, and we're using the phaco as counter pressure here. We're removing the first quadrant already. This is torsional phaco with intelligent phaco, so it'll apply torsional phaco once you approach 90% occlusion. Then it's going to give a little bit of longitudinal phaco to keep the phaco moving and to prevent the tip from getting occluded. By activating intelligent phaco and decreasing the threshold from 95% to 90%, I realized a significant improvement in efficiency. This is a fairly large quadrant to remove, and sometimes when I attempt to move large quadrants like this, it can get caught up and I have to reposition with my second instrument. But it looks like we're making good progress here. My second instrument is already behind the phaco to protect the posterior capsule. And now we're going to remove the last quadrant. All right, so pretty good here. We have, since we have done a cortical cleaving hydrodissection, you can see with just a little bit of phaco, with just a little bit of aspiration there, no phaco, we remove that remaining cortical material. Not going to have to go in with the IA handpiece here. So I will now polish the posterior capsule with the Terry Squeegee, which is a cannula with a silicone sleeve, and we can use that to irrigate and wash the posterior capsule. Excellent. I really like this the Terry Squeegee. I find that oftentimes the posterior capsule may look clear, but when you go in, there are some remnants there remaining. We fill the capsular bag with Provisc. This case is from last year, so probably I was not doing the technique where I inject viscoelastic to the right and left of the wound first. And now we're going to place the intraocular lens. So the reason I chose this case is because as I place this intraocular lens, I realized that the lens has been damaged. As it went through the inserter, for whatever reason, the lens has been damaged. And oftentimes we'll see this, but in this case, it was close to the center of the IOL. So I felt that I should probably go ahead and remove it. So this is a patient who's undergoing a MIGS procedure as well. So we're tilting the scope, and then we're going to cut the tape around the patient's head. Let me forward this piece here and rotate the patient's head 35 degrees away. And I'm also going to tilt the scope 35 degrees so we get a good view into the anterior chamber angle. This is a streamline procedure. We'll slow this down here. This is done with, I don't like when my gonio lens has those watermarks on it, but nonetheless, we still have a good view here of the angle. This is the older streamline with the blue sleeve, not the clear sleeve. And we'll see if we're able to make out here what it is we're doing with the streamline. So the streamline procedure, streamline device is really nice in that it does a canaloplasty and a goniotomy simultaneously as you click the depressor, which you can actually see here right underneath my finger on the right side of the screen, that blue depressor. It looks like the patient's moving here a little bit, which can make it challenging. I don't have the greatest view, but we go and approach the trabecular meshwork and we depress the activator and we get which we couldn't really see that because my finger was in the way, but we get a canaloplasty in that the viscoelastic comes out of each side of the cannula to the right and left into Schlemm's canal. And as the cannula pierces the trabecular meshwork, we get a goniotomy at the same time. So we've done, it looks like 4 activations so far. I'm trying to get a little bit of better view here, but we already see some heme reflux there from the goniotomy, and not really the best focus here. And what I did there is, as I was holding down the depressor, I moved the cannula to the left and created just a micro goniotomy, extended that goniotomy incision a little bit. Very good. So it looks like I'm doing that again, just to extend the goniotomy incision. You can see that little white streak there where you can see into the inner wall of Schlemm's canal. When I first started doing these, I would go in with Provisc and just really open that up. Looks like I am going to do that actually. So here I'm going with Provisc and I'm going to inject there so we can really see that goniotomy. And then yeah, perfect, right there. Small goniotomy cleft, maybe about a clock hour and a half. But the microgoniotomies are really over 3 to 4 clock hours there. So we rotate the patient's head back, and I'm not going to fast forward this. But in any case, we rotate the patient's head back. There's now Provisc all over the cornea. I'm going to have my tech irrigate that Provisc off. I used to use Viscoat initially, but now I just use Provisc because it comes off the cornea just so much easier than Viscoat. And now I'm looking at this intraocular lens. What should we do with this intraocular lens? I'm trying to decide whether I am comfortable with that little irregularity there. It's hard to see in the video, so I'm going to go in with IA, and I'm going to see if it's something that's just stuck on the lens or what exactly it is that we got here. I go in initially in viscoelastic removal mode, which is where the aspiration rate rises very quickly and the vacuum rises quickly, because I'm trying to remove all that viscoelastic, and then I'm going to switch to cortex removal mode, which has more foot pedal control over how quickly the aspiration and the vacuum rise. So we're doing some cleanup here, removing the cortical pieces, and you can see that linear streak there that's in the IOL. I go behind it, I'm trying to polish that off. Is it something that's stuck on there? And unfortunately, it looks like it's still there. So we see 2 little opacities there, and they're so close to the center of the IOL. I'm really not happy with that. What a shame to leave that in the eye, and if a patient has an issue with that or has glare or dysphotopsia from that, then that would really be disappointing. I'm not sure that the patient would have an issue with that, but I really don't want to take the chance here. So I'm debating here, and I think I've already decided that I'm going to go ahead and exchange this lens just because I don't like the way that is. Some remaining cortical material there. I'm just going to spend some time cleaning that up. I've probably already told my nurse to open up another IOL. And so I'm looking at here, and interestingly here you can see the 2 Purkinje images. The one Purkinje image there that's upright that you see from the scope is on the cornea. Yeah, I'm still looking at it and trying to clean that off with the IOL. But the second Purkinje image that's moving around is off the back surface of the IOL. And you know that that's the 4th Purkinje image because it is inverted relative to the first. So you'll see in the first Purkinje image, the brighter one right in the center there is more stable. You have the two dots in the bottom. In the fourth Purkinje image, the one that's moving around, you have the two dots on top. And that's actually a really nice little hack to use in terms of centering your multifocal IOLs, is to line both those Purkinje images over the central button of the multifocal IOL. In any case, I've decided I'm going to exchange this lens. I fill the anterior chamber with viscoelastic, and I'm going to rotate this lens out of the capsular bag and into the anterior chamber. I've posted some videos in the past about IOL Exchange, and I'll try and link to those videos in the description here. But I got to credit Uday Devgan, Dr. Devgan, with showing me this technique of the twist technique of removing the IOL. It is a relatively, is a very, in terms of OR time, a very efficient way to remove the IOL. And I'll try, hopefully demonstrate that here with this case. You have to prolapse one of the haptics out of the anterior chamber. So I'm probably going to put in a little bit more viscoelastic here. Yeah, looks like that's what we're doing. We want to protect, of course, the corneal endothelium as well as the posterior capsule. Two very delicate structures. Looks like we're using Viscoat here. Actually, I'm not sure whether we're using Viscoat or Provis, but it looks like Viscoat. And then we're going to prolapse that haptic out of the anterior chamber. I may have asked for a cyclodialysis spatula to keep the IOL, to protect actually no, what I asked for is a keratome to enlarge the incision. I like, with the twist technique, it's really hard to do that through a 2.4, so I'm enlarging the incision just a little bit here. Maybe that's a 2.8 now. Maybe even it's a 3 millimeter incision. So once we've done that, I'm going to prolapse one of the haptics out of the anterior chamber. We're going to use angled Kelman or angled McPherson forceps or Kelman forceps to grab the intraocular lens. I'm going to use a cyclodialysis spatula over the IOL, and we're going to rotate our wrist. So we'll start out with supinating, and we're going to pronate our wrist counterclockwise, and then pull that IOL out of the anterior chamber. So here I'm just putting some more Viscoat over the IOL. I want to protect the corneal endothelium. Remember, this patient's just coming in for routine cataract surgery. We've found that the IOL really has this scratch in the center, and we want to exchange it. So we tell the patient there's going to be, the surgery's going well. There's going to be a little bit we're going to spend some time just putting in, I think I told the patient I don't like the lens. I'm going to put in a different lens. And the patient's doing well, and the patient is comfortable. So got to get a little bit more purchase on the IOL than what we've gotten here. And because the wound is small, I'm trying to use these forceps across the anterior chamber. So I have it looks like I've opened up the MST micro graspers here to help me get and position this IOL. I'm going to have to rethink this philosophy of showing these videos unedited. It looks so much nicer when you're able to edit out all these extra steps you do. But I think it's important to learn to see all these different things that we do during surgery and not just give you the final polished product. The nice thing I like about this is you see, the struggles that we have, all as surgeons. Not everything doesn't always go smoothly during surgery. The important thing is to be able to manage things properly. So here, putting in some more viscoelastic here, we've got this large forceps in the wound, so we're going to lose Viscoat. And I'm just coating both above and below the IOL. And then the next step will be to bring in that cyclodialysis spatula to protect the corneal endothelium and keep the IOL back as we rotate this lens and make it smaller and pull it out of the main wound. So there we go. That was fairly atraumatic. And the reason that was fairly atraumatic is because we did enlarge the incision. So the IOL is out of the eye. We're probably going to put a little bit more viscoelastic and then inject the new IOL here. Let's see if I can speed that up a little bit. So this is not ProVisc. You can see there's a little bit of interface between the ProVisc and the Viscoat. And now this is a new IOL. This is now 2x speed. We're going to go in with the IA handpiece. Important to note now, actually I'm going in with a second instrument here just to position the IOL. Good optic overlap as far as the capsule rex is concerned. Important to note now that we've enlarged the incision, I can't use the same sleeve or otherwise the wound is not going to be watertight. So I'll have to use a larger sleeve, which I may have done here, or I may have gone with the smaller sleeve and just allowed fluid to egress from the wound. I guess we'll find out soon here. No, it looks like I've changed with the bigger sleeve. We're still getting a lot of fluid egress around it though. But in any case, we've removed pretty readily there the viscoelastic. This is sped up. This is 2x speed. We still have a little bit of cortical material there that we've removed going behind the lens because there has been viscoat now filling the capsular bag, so it's important to remove as much viscoelastic as possible. Happy with the way this lens looks. I'm happy with the way the lens is sitting and with good capsular overlap all the way around. And now we're just going to hydrate the wounds, hydrate the upper lip of the main incision, and then we fill the eye with BSS through the paracentesis. We're happy with the pressure. That's really about it. I got more from this case than what I expected, but I was happy with the result and the patient did very well. Thank you for watching. Please leave any comments or thoughts. Thank you very much. All right.